Well, I mean, I think it's a big deal because it's the first perioperative study that, shows a clear signal for perioperative immunotherapy. So, I mean, whenever you have something that is translatable on some level from metastatic disease to earlier lines of disease, it is reassuring. And, despite a couple studies that almost made it, um, earlier. This one is a large global study that met its endpoints in all respects. So, in that regard, I think that's why there was some enthusiasm. Perioperative chemo, at least for the majority of the Western world, has been the standard for a number of years. Probably FLAUD emerged about 4 or 5 years ago to become a superior chemotherapy regimen in those patients who can get it. It's been extended on some level to some Asian countries as well. So there is some global sort of coalescing behind the notion of perioperative chemotherapy in the disease, generally speaking. And so FLOT, while a very difficult regimen for a lot of patients, and we can't really get around that. It is not an easy regimen, and that's why some of the data that you see is a little bit challenging to extrapolate into the real world, where a large majority of patients are not necessarily sufficiently fit and optimal to get full dose FLOT. So just keep that in mind. But in the study that was done here, it's very large and relatively simple study, and I think that's why it stood out. Simplicity is sometimes important, and answering questions with a straightforward question and answer, which I think more or less the study sort of was able to do. And what it did is randomize patients to either chemotherapy plus placebo or chemotherapy plus FLOT, giving the chemo plus FLOT for a few months before surgery and then a few months after surgery, followed by maintenance durvalumab or FLOT. And the idea, maintenance durvalumab or placebo, excuse me, for another 10 months. So study met its endpoints for event-free survival, which means that the regulatory endpoint and primary hurdle was met, improving the event-free survival from the standard, which was 33 months of event-free survival with FLOT, which very much is in line with our controls for this regimen. And the median wasn't reached as of this data cut. So in almost all of the subgroups, obviously, the benefit was favoring durvalumab plus FLOT. So, the overall survival did not quite meet statistical significance, although the expectation is high that it will, just based on current projections. So where we stand right now is, I think, a de facto change in the standard of care to durvalumab plus FLOT moving forward. What remains to be seen, and what is a critical question, is, do you need all this durvalumab after chemo and I think after surgery, excuse me, and that wasn't addressed in the study, and I think subsequent studies will need to be done to answer that question a little more carefully. I would expect that this regimen would be submitted and ultimately approved for registration. It met its endpoint of event-free survival, which is a high surrogate for overall survival in this context. Again, we need an overall survival endpoint, which hopefully we will. I think that will require a little more time, but hopefully very soon we'll have that data. I mean, the study was global, which is hard to do, and which is why I think it has extra validity on some level, because it enrolled all patients from all over the world, Asia, Europe, US, South America, and did represent, I think, overall a broad overview of the cancer. The subgroups are all pretty much favoring the durva group, including primary tumor of gastric or GE junction, you know, TAP score, which was PD-L1 score, greater than 1%. Keep in mind the numbers were very, very small for this PD-L1 zero group. So that group was only made up like a total of like 100 patients, so like quite less than 10%. So it's a little hard to extrapolate into the PD-L1 less than 1, but even in that group, there was some benefit to durva, MSI high certainly, and others. So overall, I think that we are convincingly convincingly clear that durva plus FLOT is the new standard. One of the key things with this kind of thing is you want to make sure that you're not delaying curative surgery or disrupting post-operative recovery. It's pretty clear that there was no difference in that regard. Obviously, you're going to add immune-mediated adverse events, and durvalumab is a potent PD-L1 inhibitor, so you're going to have an increase in that kind of toxicity profile. But there was no significant change in the ability of patients to undergo curative surgery or complete surgery and adjuvant therapy. So is it right for everybody? Obviously not. I think we have to rely on clinical judgment to decide when this regimen should be utilized. The FLOT itself isn't right for everybody. So how this is extrapolated to other chemotherapy regimens is not yet clear. I think there will be some extrapolation for certain, but overall, I think the data in aggregate supports the addition of durvalumab to this chemotherapy regimen. Yeah, I mean, I think we need to wait and see what the overall survival tells us, which is a very important regulatory endpoint and also a clinical endpoint, obviously. So that's coming shortly. Thereafter, I think there's going to be a lot of translational stuff to learn from this analysis. Who were the patients who derived the most benefit is still not entirely clear. So I think some of that will be determined from the upcoming data sets. And we're going to need some new trials that obviously are going to ask those kind of questions, contribution of phase, and otherwise, that are being designed right now.